This is the case of a 54-year-old male nurse who had fever and dyspnea and didn't go to work, and had mildly elevated CRP values. He was, had a blood test drawn by the family doctor, and then he called up and, in the hospital he was working at and said, I just can't come to work. And they asked him, what do you have? He said, well, yeah, I have fever. And then, one of the doctors said, why don't you come in? I'll take a look at you. And so that's what he did. He came in, and they took a look at him, and they had, all sorts of, diagnoses that were possible because obviously fever, he had a bit of cough, so there was the suspicion that he had pulmonary infiltrates, but that did not really show up. His pulmonary function test was normal, and so was his chest x-ray. But since he worked on a cardiology department, one of the people just grabbed the echo machine and did an exam on him. Okay? I'll show you this exam later on, but before I do that, I want to also show you the ECG that they wrote. Okay? I want to just leave you alone with this ECG for a few minutes and give you a chance to take a look at that. Remember, he's a 54-year-old man with fever and a bit of elevated CRP. I'm trying to show you a lot of other imaging modalities and other tests as well, because I think if you want to learn echocardiography, you have to really put this information into a clinical context and into the context of other imaging modalities. So the ECG now does give you a bit of information which will be important later on. But let me now turn to the echo that was performed. Of course, I do not have that echo, but the patient was then later transferred to us, and I repeated the echo, and this is the repeat echo that I did. Okay. Okay, this is the echo of the patient now. So there is a bit of left ventricular hypertrophy. As it turned out, the patient had hypertension that he was not aware of, 12, 14, somewhere in that range. And the reason they sent him was because they thought he had endocarditis. Okay? What you see here is you see the aortic valve, and there is a suspicion that there is a structure on the aortic valve. You see? Right here. Let me give you a few more images, and I want you to make up your mind. Okay? The important thing is that when I show you these cases, I want you to kind of be in the driving seat of the one who has to make the decision. And now just imagine you're performing this echo. The referral diagnosis is patient with fever, elevated CRP, and what does this patient have? Does he have endocarditis? Okay, I'll just give you a few more images to take a look at. Okay, also look at the mitral valve, at the other valves, myocardial function. Look, this is here the mitral valve now. Luckily, the patient has better image quality than before, than the patient before. This is the aortic valve again here. Okay, and now I will ask you a question. My question to you is, what is his problem? Do you think he truly has endocarditis? Do you think he maybe has myocarditis? Do you think he has heart failure with normal ejection fraction? That's the abbreviation for what I put on here. Do you think he has coronary artery disease maybe, or does he have something else? Remember, usually if you go to these lectures and they give you the chance to vote, and they have the option which is called something else, and it usually is something else because obviously they want to hide something, and that's why they put something else, because the true diagnosis is hidden somewhere behind there. So the likelihood is probably big that it is something else. Okay, I think now we'll show the results. Good. Okay, let me see. Half of you do think it is something else, while nobody really thinks it's heart failure with normal ejection fraction. It's kind of an awkward decision to make because it's a young patient. You don't really see heart failure with normal ejection fraction in patients who are young. 17% think it's endocarditis, 22% think it's myocarditis, and 9% think it's coronary artery disease. Okay, let me now go to the loops again, and I'll show you a few things which I think you really have to pay attention to. Okay, now here are the loops again. Good. The question obviously was endocarditis, yes or no, and then we performed a TE study. This is the TE study I'm going to show you, because with TE we have to obviously find out if the valves have vegetation or not, and TE is obviously superior to transthoracic echo. Okay, so this is the test we did before we did the TE, and now let's go to the TE study, to the aortic valve. Beautiful view, as I would say. No question, the patient has a tricuspid valve. You have 3 cusps. You can just slow this down a bit. You can see the typical motion of the aortic valve with the 3 cusps. Okay, this is the A coronary cusp, this is the left coronary cusp, and this is the right coronary cusp. And there is thickening, no question. If I just stop this image here, there is thickening right here, a bit of sclerosis, maybe a bit more than I would expect from a patient who is still rather young, I think 55 or so. But do you really think that there is a vegetation here? Maybe right up here. But then again, you know, this is more calcified than it is soft. Usually if you have, you know, infectious endocarditis which is still active, the thickening and the vegetations are kind of more jelly-like, or I would say echolucent, while this is more calcified, so it kind of looks more like sclerosis than a vegetation. So from my point of view, if I see this, I would not make the diagnosis of endocarditis. If you put the threshold so low, then I'm sure that you will then you would probably make the diagnosis in too many patients of endocarditis. It's certainly not as endocarditis. Okay. Now, of course, the patient has dyspnea. Philip just made this comment, and it's a very good comment that he made, actually, because what I really like to do is I always like to show you a few things and then kind of show you the real diagnosis without pointing to the problem. But now I want to show you what you could have seen and you might have missed because I distracted you from seeing it, for a simple reason that I want you to focus, on these things and concentrate on other things as well. If you look at the apex here, you see there is a wall motion abnormality here, right? Do you see this? No question that there is akinesia here, right? This is not normal wall motion. The image quality here was not so good. This was an older system we used, but still, if you look closely, you can see that there's a wall motion abnormality here. Okay, right here, right in the apex. I will now go back to the study I showed you before, because here we have a better image quality, and I think you will now appreciate the wall motion abnormality much better. And let me again show you the same loops. And now forget about the aortic valve. What we see here is just an artifact, and right here is the calcification we saw with the TE study, so there is no endocarditis. But you can kind of almost appreciate that there's a bit of a hinge point here already in the peristernal long axis view. And if I go to the apical views, right, take a look at the apex right here. You see there's a wall motion abnormality right here, all the way around here. The basal portions of the myocardium seem to contract quite okay. And the same thing is true here for the basal septum and the mid septum, I would say. But right here is an area which looks very suspicious. Another view, apical long axis view, right here. Okay. There was a comment by Philippe questioning if there could be a thrombus in here. Very good question indeed. If you take a close look at right up here, you will see all these echoes here. This could very well be a thrombus. If you have a wall motion abnormality, then there is a higher likelihood that you would have a thrombus there. But to be honest, this does not really have much connection with the wall. And what you often see is you see kind of diffuse echoes which might simulate or look like a thrombus, which are simply caused by near field artifacts and by reverberations that you have somewhere up here. So this in reality I would not think is a thrombus, But if you really want to exclude it, sure, you would have to inject contrast and see if there's something in there. But my thoughts would not be that this is a thrombus. But what is very important is to look at the myocardium from different angles. This is a view that I like to use if I'm looking for supraapical infarcts. I kind of tilt the transducer more laterally and point it more towards the apex, and then I see the regions that I would usually not see in a normal four-chamber view. Okay, this part of the apex, I mean, I'll just demonstrate this to you. I think this will kind of give you, my thoughts here. This is the length of the ventricle, right? It's 88 millimeters. Okay, now I'll show you the normal four-chamber view. And if I use the normal four-chamber view, and I use the caliper, I only get 81, which means I'm missing almost a centimeter up here, right? And this centimeter can be displayed if I use a position where I image more from the side and tilt the transducer as I did right here, okay? And here we now see very nicely that there seems to be a wall motion abnormality, and not even that, not only a wall motion abnormality, but that the ventricle is also thinner. Now, coming back after we saw this, we talked to the patient again, and yes, he did have dyspnea, and then we kind of found out that his dyspnea was not only present since he has this infection, but that he had dyspnea now for weeks and months. And then questioning even further, we found out that he had chest pain on exercise, and this had been going on for months already. So from my view, I think we were on the wrong path. This patient does not have an infectious disease of the heart, but he simply has coronary artery disease, I would say. One thing, however, I want to mention as well, there is an option also that it's myocarditis. Myocarditis can sometimes be of regional nature, but to be honest, this is very closely linked to a very typical territory of the coronary arteries. To which coronary territory? What do you think? Any comments? Yes, it would be the LAD territory. This would be my suspicion. The next step in the procedure would then be to perform a myocardial scan. And now I will show you what the scan showed us. This is the scan. We performed a thallium stress test. You see the stress images here, and you see the rest images here. And I don't know if you're familiar with stress tests or with nuclear medicine techniques, but what you do see here is similar cut planes that you would see in echo. Those are short axis views, which you kind of add together then to create a kind of a bull's eye display, as well as views which are similar to the four-chamber view. This would be the four-chamber view, and this would be the kind of the peristernal long axis view if you want to. Here is the four-chamber view. This would be the septum, the apex, and the lateral wall. And if you put all this together, you can get what's called bullseye display. And this bullseye display shows you when you perform stress, you have a very distinct defect in the apex, in the anteroseptal region. And if you wait some time and repeat the images at rest, then you have partial recovering of the perfusion in the apical region, but there still is a bit of persistent perfusion defect which is present also at rest. What does that mean? It means that you have ischemia, reversible ischemia, and you also have a scar, right? So it's kind of both infarct with the region around the infarct still having some form of myocardial perfusion. Good. So the next step, obviously, since it's a young patient, is to perform coronary angiography, and we brought him to coronary angiography, and here are the images. This is the LAD. You have the coronary artery right here. This is the catheter which is stuck in the left main. And then you have the split into the LAD and to the circumflex artery. And right here in the LAD, you have a number of different narrowings which are very severe right here, here, and then you have another one right here. So there is no question an LAD problem, which is proximal LAD problem. There's a small minor problem here also in the circumflex artery. So The interesting thing here is that you have a patient who is rather young, who had symptoms which are, I would say, were more or less typical, but he never really gave us the information until we questioned him and pinpointed him to the problem, and where kind of fever masked the problem that he really had. What do we do next? We obviously bring the patient either to intervention or to bypass surgery. In this case, we prompted to perform bypass surgery to the patient. But before I show you a few more image loops which are interesting for the further assessment of patients with coronary artery disease, I want to just show you the right coronary artery right here. You see that the right coronary artery is rather okay. You have a large right coronary artery, but it also shows some narrowings, but no significant stenosis. Right? Maybe down here there's a bit of narrowing in the descending part of the, or ICA, and maybe here as well, but no significant stenosis. Before I go on though and show you what else you can extract from the information of the echo in such patients, my question to you is, do you use speckle tracking echo? And while you answer this question, I will answer your questions. There was a question, or at least a comment, by Ayman, if this could be an autoimmune disease like SLE. Well, certainly SLE can cause fever and can cause also, myocardial problems, but I would say it would be very unlikely. It would not be a very typical manifestation of SLE. I would rather expect the patient to have pulmonary hypertension. This is the usual cardiac manifestation of patients with SLE, at least of some patients. But of course, they can also have, coronary artery problems as well. And then the question was also, what about viability? Can we assess viability with echo? Well, this is a very good question, which kind of fits into the question that I'm asking you, and I will explain that to you as soon as we get the poll and as soon as we know what you answered. Okay, good. Okay, this kind of shows me what I was expecting to see, namely that most of you are not really using this technology, which I think is a pity because it is such a fascinating thing to do. And I truly believe that this is something which will revolutionize echocardiography. As a matter of fact, it already is. Let me go and show you what we can tell or how we can use it in this patient. Okay, this is the patient we have here. And to perform speckle tracking echocardiography, all you have to do is you have to use the apical views, a 4-chamber, a 2-chamber, and a 3-chamber view. And what you then do is you simply go into these images and you perform kind of an, let me go back. One second, I just have to get this window away somehow. Okay, here we go. Okay, all you have to do is you mark the basal parts of the myocardium and kind of the apex, and then you would get a contour of the ventricle, and the system does everything else by itself, basically. It calculates the strain, and by doing so, it gives you values for the specific regions. And then it displays the results similar to the way that we had it in the thallium stress test. And the result we get here kind of tells you if myocardial function is okay in these regions, namely longitudinal function, which is a very, I would say, a sensitive marker of myocardial dysfunction. And if we go into these image loops here, I will just focus on this here, you see that there are certain regions which have normal contractility, those are the very deep red ones, and others which have less contractility. Those are the kind of lighter red or pink colors. And as a matter of fact, here you see that exactly those regions where we suspected wall motion abnormalities also have reduced longitudinal function. Now, in this case, you might say, so what? I see it with a clear eye anyway. But I can guarantee you there are a number of cases where you will not be able to see it with the eye, but where speckle tracking gives you additional information.